everyone. Welcome to today's webinar, where we will talk about how are costs and medicine effectiveness part of decision-making in medicine access. My name is Monica Rakovica. I'm Access and Policy Manager with Myeloma Patient Europe. And today's agenda is, after welcome and introduction for 10 minutes, we'll have our speaker for today delving into the details of the costs effectiveness analysis for 45 minutes, followed by a Q&A session for approximately half an hour, and we wrap up and close around an hour and a half. Before I give Frederick the word, just a few housekeeping rules. You should be able to see and hear the two presenters, myself and Frederick, but you will not be able to see or hear any other attendees. If you having some technical issues, like for example, you cannot hear the presenters, make sure that your speakers are not muted and the volume is set up high. When you want to post any questions, please do use this Q&A box that you will be able to see on the toolbar at the bottom of the window to post any questions. You can also click on any question that are already posted there if you believe that any of them are particularly interesting. Please do write those questions in this Q&A box and not in the general chat. We generally use that window to, if you want to chat with any other participants, share your experiences, or post any other comments. If you're having issues with the poor video, for example, or a poor signal, you might consider better attending using only the audio mode. If you have any other technical difficulties, please let us know in the general chat function and someone from the MPE team will reach out to you. Today's webinar will be recorded and will be available a few days later on the MPE website, on our social media channels. Will also be available on the Horizon Europe ASCERTAIN project website and social media channels. And since I mentioned ASCERTAIN, today's webinar is organized as part of a package of patient engagement and educational activities under this project. A few words about it. ASCERTAIN stands for Affordability and Sustainability Improvement through New Pricing, Cost Effectiveness and Reimbursement Models to Appraise Innovative Health Technologies. It is a 4-year project consortium, which is led by Erasmus University, and it aims to create new policy tools to promote access to medicine for patients. Patient involvement in ASCERTAIN, it has a very important place, and MPE, it's a full partner in the consortium. We are involved in all packages to help promote patient understanding, in also to seek feedback from patient and patient advocates on the results of the project. There is also an advisory board, which is overseeing the progress of the work, and it includes representatives of various patient organizations. Now, why we chose today's subject to delve into. Why is cost effectiveness analysis important for patient and patient advocates? You probably know this already, but public health budgets are limited and increasingly under pressure. And the prices for new medicine, especially for the ones in cancer and in rare diseases, are increasing. Cost effectiveness analysis is a tool that can help assess in a rigorous manner the value of the new medicine compared to existing ones. And for patient and patient advocates, it is very important to understand exactly how new medicines are assessed, funded, and ultimately accessed, so you can focus accordingly the advocacy efforts. Today's webinar is part of a series of webinars developed in ASCERTAIN. We already have 2 other webinars with recording that you'll be able to find on our YouTube channels, one on the basics of medicine pricing and on medicine reimbursement. Now, I'd like to introduce today's speaker, Frederick Thielen, as assistant professor at the Erasmus School of Health Policy and Management at Erasmus University Rotterdam. Has several hats, you can see, also a senior scientific researcher at the Trimbos Institute in Utrecht, international program director of the European Masters in Health Economics and Management. He conducts research that focuses on health economics and outcome studies with a particular focus on cancer care, mental health, and planetary health. And on top of everything, he's also trained as a nurse, working for several years at the internal medicine ward at the University Hospital in Aachen, Germany, bringing thus another layer, a very valuable layer of clinical experience to his later work in policy and research. Thank you very much, Frederick, for being here today and doing this for us.
Thank you very much, Monica, for this nice introduction. I will now share my slides and hope all goes well. If not, I will hear so. So thank you very much for the opportunity also to talk to you today about a very important topic within the ASCERTAIN consortium, the cost effectiveness analysis and health technology assessment. Here at the Erasmus University in Rotterdam, we offer a master program, Health Economics Policy and Law, but also the International Health Economics and Management Master Program. And when we teach this topic to students, we take 6 weeks. So it takes us a 6-week course to teach HTA and economic evaluation. I don't have 6 weeks today. I have only 45 minutes, and I try to condense the topic as much as possible while keeping it also accessible. And I'm very much looking already forward to the discussion later on. So I'm Frederick Thielen from Erasmus School of Health Policy and Management, and today we will ask the question, can and should we provide all treatments for everybody? We will see how costs and cost effectiveness shape access in Europe, and this is especially for cancer, rare diseases, and advanced therapies. Some examples I put at the end of this presentation. And I will connect this also to the ASCERTAIN project that you've heard about, that you can also find more at access2meds.eu, the website that we have. And we are developing practical ways to make decisions more transparent, comparable, and timely. Here's today's roadmap, and I will start with some background on why these questions actually matter. And then I will go a little bit more into what health technology, or in short, HTA, is. And I will then move to cost effectiveness, discuss some examples, and then oncology, rare diseases, but also ATMPs, which is advanced therapeutic medicinal products. So some of these abbreviations I cannot avoid because otherwise I have to say very long sentences. So ATMPs and HTA, this is some of the main concepts, but I will come to them later again. And at the end, I will also have a future outlook, but not only what ASCERTAIN as a project can do and what we aim to do, but also what Europe is doing next, before wrapping up with some key messages and a short discussion. So currently, health systems face a clear tension, as we already heard from Monica. Innovation is accelerating, but at the same time, resources are often not. Every euro that we spend on one intervention is a euro that we cannot spend elsewhere. And health technology assessment, or HTA, is a structured process that we can use to make these decisions. To also justify the cost. So HTA and economic evaluation is not about saying no. It is about to choose wisely and then within the limits that we have. So let's start with 3 basic facts. 1 is resources are finite. 2 is money can only be spent once. And 3 is choices are inevitable. So we need to make choices. And health economics does not create scarcity as such, but it helps us basically to see clearly and also decide where health gains are greatest. So before we go deeper, I would like to start with a very short icebreaker poll of a question. And this is something you can type in the chat, and later at the discussion, we will go back and revisit these answers that you gave. So when you hear about health technology assessment, or HTA, I would like to know what do you associate it most with? Is it costs and budgets, patient access, clinical evidence, and bureaucracy? Don't think too long about your answer. Just type it in the chat as A, B, C, or D, and then we will already move to the next icebreaker poll, which is why do you think who do you think should have the loudest voice in HTA decisions? Is it one, patients? Is it two, clinicians? Is it three, payers and nurses? Or is it four, politicians? So let us look first at some financial figures from Eurostat. So across Europe, what we see on this picture is that healthcare spendings as a share of GDP, so the gross domestic product, varies greatly. But in most countries, it actually increased, especially between the time period that's shown here between 2014 and 2022. Recently, I was challenged online by someone posting on LinkedIn about whether the actual spendings really rose between the last couple of years, or is this just a myth? And if the prices of medicines are really one of the major drivers. As you can see on the graph here and the following slides, you can decide by yourself what you make of this story. But what we see here is basically that healthcare expenditures as a share of GDP increased. But then if we look at not what are the countries spending, but how much do we spend per person, then the picture is even more striking. The point is that indeed healthcare expenditures increased in recent years, and that at some point a maximum will probably be reached if it's not already reached. So now the question whether pharmaceutical spendings also increased. And according to the European Social Insurance Platform, they are indeed rising, mostly because of the prices and not because of the use of more medicines. So it's not that we use more medicines, but it's actually the prices of these medicines that make these prices increase. And the annual growth between 4 and 13% is something that means payers need strong tools, like, for example, HTA, to keep access sustainable. So ACIP recommends better coordination, shared assessment, and stronger management on both prices and the evidence base at the same time. And this really aligns with the ASCERTAIN goals because we want faster and more consistent access to decisions and also to medicines. When we talk about barriers to access, money is usually the first that we think about, of course, but it is not the only one. There are also limits in workforce and resources, but still financial constraints are key. So every new treatment we fund competes with other priorities within a fixed healthcare budget. And average healthcare expenditures relative to the gross domestic product across European member states in 2021 was 11%, as you can see here, 10.4% roundabout. And just for comparison reasons, I also put the general government expenditures relative to GDP in European member states in 2022. So the figures are already not very comparable because it's 1 year later, but the most recent I could find. And this was close to 5%. When we make it more concrete, I would like to borrow a metaphor that my favorite health economist, Matthijs Versteeg, used also to explain this very nicely and beautifully in a recent Dutch podcast that I also linked at the end of this presentation. He compares the healthcare budget to a wardrobe, and with different shelves for example, sweaters, for trousers, for underwear. And now you can imagine that your wardrobe is completely full. Often this is maybe also the case. So comparing this to wardrobe is a nice example. And now imagine that the wardrobe is completely full. And when you buy a new sweater, you cannot simply keep adding more because the wardrobe will be overfull at some point. So you need to take something else out to make space. And naturally, you will not remove your favorite item. You will remove something that you wear the least, maybe. And that's of least value to you. And in healthcare, the same logic applies. The shelves in the wardrobe represent different medical specialties. So here, for example, on the left slide, you could say, think about oncology, cardiology, mental health, or prevention, and so on. And if you decide to fund a new cancer medicine, for example, or any type of new medicine, then it may mean that somewhere else, perhaps in mental health services or prevention, fewer health resources are available, and we have to take something out of there to make room for something new that is bigger or more expensive. So the question becomes, does this new sweater, for example, deliver more health for the same money or for the same amount of money than what we took out of the wardrobe? Now, of course, we can also look beyond healthcare. We can also try to look beyond the wardrobe itself and search for extra spaces elsewhere, for example, elsewhere in the economy. We would, for example, cut budgets in other sectors, education, housing, or social services, to make room for new health technologies. But each of these choices brings its own issues and challenges. Another possible route is to enlarge the wardrobe by increasing taxes or insurance premiums so that all and the total healthcare budget is increasing, and that we can spend this money then on new medicines, for example. But such increases have, of course, limits, and at some point, citizens, but also employers, the ones who pay for these budgets, reach what you might call a bearable maximum, and the contributions to society are also from society are also endless end at some point, of course, and some would even argue that we may already be close to that point. So the wardrobe analogy reminds us every new therapy requires space, and that space has to come from somewhere, either from within the healthcare itself, from the healthcare sector, or from other sectors, from taxpayers' pockets. And understanding these trade-offs is at the heart of health economics. So why do we spend so much time thinking about these barriers? Because they sit at the very center of every health system, long-term strategic goals, which are being sustainable, being equitable, and delivering good quality. Sustainability in this context means often making sure that resources are used wisely so that future generations can still access effective care, but also still our generation as well. Equity means that access does not depend on where you live, how rare your disease is, or how wealthy you are. And quality reminds us really that we want good quality care that remains person-centered, that is safe to apply, and that is also evidence-based. So our task within ASCERTAIN, but also as health economists, is to help policymakers to find the right balance between these goals, between this trias, so to say. We want to ensure that effective therapies remain affordable for all patients and that innovation continues without destabilizing the system that it relies on. And this is also exactly what the ASCERTAIN project aims to support across Europe. We want to improve how countries judge, value, and share evidence and keep access both fast and fair to these new technologies. So let us move now from the why to the how. So health technology assessment is, of course, at the core of this presentation, and it is a structured process that we use to translate this scientific evidence into decisions about treatments and which ones to fund and how to use them wisely. It connects really research and real-world policy in that sense. So on this slide, you see the core domains of health technology assessment, or HTA. This can range from clinical effectiveness, safety, and clinical performance, and current use. Together, they form the broader domains, and such as economics, ethics, and organization and society and law are also part of that. There is the relatively new EU Health Technology Assessment Regulation, which is already in place. And the first group, so the upper part of this slide, the current use of the technology, but also all the technical aspects of any new intervention that might come to the market, including its safety and the clinical effectiveness, they will soon be assessed centrally through joint clinical assessments. Some of them are already, and this will expand throughout the next years to even more and more categories. So cancer care, for example, is something that is already now under review, but many other domains will follow as well. That means also that all the member states in the European Union will share the same clinical evidence. And this is really brand new, because before that, we had every country doing their own analyses, and now the aim is to have one central assessment of these effectiveness parameters for health technology assessments. But when we look then at the top bar of this figure, then we have some remaining domains, like, for example, the economic and the social dimensions. They will also for long stay at national level, because they reflect how each health system really organizes its own health system. And if you go back to the wardrobe analogy, so their own wardrobe of care and what each society values most. So at this point, only the top part of this picture is done centrally through the EU HTA regulation, and the lower part is still at national level. The EU HTA regulation is indeed a major change because it has a big impact. And from 2022-25 onwards, Europe will begin conducting these joint clinical assessments, and first for new oncology drugs and advanced therapeutic medicinal products, ATMPs. And over the time, this will expand to other areas as well. The goal is quite simple. We want one shared clinical assessment instead of 27 repetitions, which should reduce duplication and also should speed up patient access, especially in countries with slower HTA processes at the end. So at the moment. So not everybody will gain, not every country will gain, but some of them will more than others. So the economic assessments, they still remain at national level. And here is where ASCERTAIN comes in. We are testing how transparent, standardized and reusable economic models, and I will show some of later how we do this, can really help to build for the countries to build a shared EU evidence, also maybe going beyond only the clinical evidence and sharing that. So now that we understand a little bit more how HTA is structured in the decision-making process, I would like to focus a little bit more and discuss what cost effectiveness is. In simple terms, cost effectiveness means asking if we spend a bit more money on a new treatment, how much extra health gain do we get back? So it's not about saving money, but it's about looking how money that we want to spend or need to spend can be spent wisely. It is not about cutting costs, but it is about making sure that the money we do spend brings as much health benefits to society as possible and to patients, of course. So we want to get good value for every euro that we invest in healthcare, and we don't want to spend money on things that have no or little value to us. And to describe that relationship between money and health, we can use measures like the so-called incremental cost effectiveness ratio, or the ICER. And that sounds quite technical. So I would like to ignore that formula for a bit and think of it in more simple terms. So imagine you have two treatments, an old treatment and a new one that's coming in. The new one is often a little bit or much more expensive than the old one, but it might also help people to, for example, live longer or to feel better. This is often the goal of new treatments, of course. So then cost effectiveness would ask for every euro that we spend on the new one, for every additional euro, how much extra health do we get compared to the old treatment? So if we gain a lot of health for a small increase in costs, that is good value. If we spend a lot of money for very little extra health, then this is a bit less of good value, so maybe also poor value. And because, remember, if we spend more than we already have, we need to take this extra spending from somewhere else. So either in the healthcare sector or outside of the healthcare sector. So the cost effectiveness has two parts. That's the costs and effects. And when we talk about costs in healthcare, we need to be very clear about what we actually include. It is not just the price of the medicine itself, to buy the medicine and to apply it. We usually distinguish between three major categories. One is the cost within the healthcare sector. Think, for example, of hospital stays, all these different tests, blood tests, and so on that need to be done. Surgery could be part, medication, of course, but also nursing care and rehabilitation. But then there's another layer, the second category, which would be costs for patients and families. For example, traveling to the hospital and back, but sometimes also out-of-pocket payments that patients do. Or the value of time that relatives might spend together with the patient and maybe also to care for the patient, providing care. As a third category, we can also think of costs in other sectors. Examples here could be, for example, productivity losses when illness prevents patients to go to work, and so they miss work and miss income, or even savings when treatment helps them to return back to work earlier than maybe the old treatment. And different countries take very different perspectives on that. They use one, two, or three of these categories for their assessments. And in the United Kingdom, for example, the analysis is usually only including health system costs, so the first layer. And in the Netherlands, the guideline for economic evaluations in healthcare is taking a societal perspective, and this would mean we would include all these three layers of costs. So when we talk now on the cost side, there's also the effectiveness side. So in the effectiveness side, we often talk about quality adjusted life years or life years. So two approaches. We can look at only the life years that are gained with giving this new medicine, but also the quality adjusted life year. So there are two main outcomes. On the one side, mortality, which is maybe saving or prolonging life. And on the other side, the aspect of improving quality of life. And when we combine those measures together in one outcome, this is what we often refer to as quality adjusted life years, because on the left side would only be the life years that we look at. So how much life did we save? And the other part is also the quality. So the quality adjusted life years. And I would like to bring a simpler example than just this formula. But the idea behind this formula is quite simple. We take two ingredients, so the VQ, which is the value function. This is the value of someone's health on a scale from 0 to 1. So 0 in this case would represent the state of death, and 1 would represent perfect health. Of course, most people are somewhere between 0 and 1, maybe not always feeling perfectly healthy. So 1 is maybe rarely achievable, but somewhere maybe below 0.98 would also be something meaningful. What we then do is we multiply by the years. So the value function would be something between 0 and 1. Let's say 0.8, for example, because maybe someone like I have a cold maybe, and I feel 0.8 today. And we multiply this by the years that a person lives. And this together gives the quality adjusted life year. So the quality adjusted life year will always be a little lower than just the life years if these are not spent in perfect health. And this is a simple example. If you imagine a person, for example, who lives for 80 years in perfect health, then the quality adjusted life years would just be like the life years, because perfect health in this weight would be 1, and then we multiply 1 times 80, and we have 80 quality adjusted life years for a person that lived 80 years. We can also look at this graphically. On the x-axis, we have the years that this person lived, and on the y-axis, we have all the possibilities between 0 and 1, and this person lived for in perfect health. So all the 80 years are filled with ones in this case. But then we can also look at a more complex example. And the second example here, a person that develops severe chronic neck pain, maybe halfway through life. Still, life years 80 years. This person lives 80 years. But for the first 40 years, this person actually had perfect health. And then somewhere in between, in the middle, the quality of life drops from 1 to 0.5 due to this very chronic, severe neck pain. And the remaining 40 years are spent with a quality of life of 0.5. So the first 40 years in 1 and the last remaining 40 years in 0.5, we would add this up together. So this person would live 80 years, but only 60 of those in 60 quality adjusted life years. Up to now, we have learned how to calculate QALYs and also what to think about cost and how to include those costs. So cost effectiveness, these are basically the two main part and the most ingredients, costs and effects. But we also need to know when we decide that something is actually cost effective. When do we talk about cost effectiveness, and when do we say that something is worth its costs? We can look at this also graphically. We can plot additional or incremental effects on the x-axis and the incremental costs on the y-axis. Remember that the cost effectiveness analysis is always a comparison between an old and a new treatment, or could also be two old treatments. Of course, it doesn't have to be old or new, but it's always a comparison. It's not only looking at just one medicine or one therapy, it's always in comparison with something else. So then we can calculate the incremental effects. And if we would see that we get more effects and less costs than the other one, then we are, of course, very happy to integrate this into our health systems. We don't ask any questions. We even talk about this medicine or this therapy being dominant, because we get even more value for less money. Then we have this money over to spend it on other things. On the other side, we can also imagine a scenario where the new intervention, the new therapy will actually increase costs. So we would have to spend more than the comparator, but we would also lose some effects. So here we go on the left on this x-axis, we lose effects, we lose quality adjusted life years or life years, and we have to pay more. This is also a no-brainer. Here we would not want to reimburse or integrate this treatment in the healthcare system. And the difficult areas are all those that are remaining. So here in this graph, the northeast and the southwest quadrants, where we have more effects, which actually sounds good, but not always at all costs. On the other side, we can also say it would be nice and it would be good that we save some money and we can put it somewhere else. But we also do not want to do this at the loss of all these effects. So these two quadrants are the really difficult ones for us to interpret. And to help us interpret, there are thresholds that come into play, and we might want to define these thresholds beforehand, before we make the decision to keep it a little bit more fair and just. And then this line would be a threshold that we define. And then we could say, you know, if it's below the threshold, then we would reimburse the treatment. But we can, of course, think of very different and many different thresholds that we want to apply. And really, depending on this threshold, we would say then treatment is cost effective or not. It is good to know that in most countries, also these thresholds are not fixed. They vary across countries and also sometimes even within healthcare systems. If a budget is tight in some countries, then the threshold is usually a little bit lower. The system is more flexible and more productive. It can often afford higher thresholds. And when we compare across disease areas, for example, cancer versus prevention, also the trade-offs become even more complex. So thresholds are not universal prices for health, should not be understood as that. They are reflections of what a society can or want to afford, and when it chooses value for money. Maybe not directly related to thresholds, but I want to highlight the patient involvement in HTA2 because they play a very crucial role. And they bring lived experience and help understand what outcomes really matter and how treatments affect daily life. Across Europe, involvement is increasing. So in many member states, this is increasing, and I think ASCERTAIN is a good testimony to that. But a report showed also that it is very uneven between countries. Some countries involve patients early and others only at the final stages. And for projects like ASCERTAIN, the transparency is really key. This is also why we involve patients at every step in every work package. We want to make the models and evidence easier to understand. We want to make it easier for patients and advocates also to follow the discussion, to contribute informed feedback, and to strengthen fair and timely access decisions. Across Europe, HTA bodies are actually making real progress in involving patients, I would say, but there's still no single standard for involving patients. And according to this analysis that I present here, patient input happens most often during very early advice and committee reviews, but it gets a little bit washed out throughout the process. This report also highlighted 3 success factors for involving patients. So this is training and preparation for both patients and also the ones that assess. Early involvement before evidence is finalized, because once it's finalized, it's very difficult to change that, of course. And feedback on how patient input shaped the outcome. So this closed feedback loop at the end, this is often missing, and this is also why we do these seminars. And I'm very much looking forward to the discussion. I will now move from the principles of real to a little bit of real examples. And to the specific applications of HTA, because HTA is a broad concept, can be applied in many areas, but some are very and especially complex, like, for example, cancer or rare diseases, and also ATMPs, for example, gene therapies and cell therapies. In these specific cases, evidence is often very limited and prices are very high, which makes it even more interesting to look at cost effectiveness, but also more challenging at the same time. little bit about cancer medicine. Each year, new cancer medicines enter the market, and they are often very highly priced. So very high prices for these new medicines. And what we see often is that there's only small gains in survival, but also in quality adjusted life years. Some are cost effective, but a recent study also found that most of them are actually not. This is a study that compared 11 cancer drugs in the UK and the United States, and they found agreement when those two countries looked at these seven cases. In 7 cases, they found agreements, and they have found disagreements in assessment in 4. In both countries, 7 of the 11 drugs were not considered cost effective, and this was mainly because of the price difference and the uncertainty about long-term benefits. So there, the evidence base was not really clear. And if you look back at the wardrobe analogy, this reminds us that oncology is the shelf that fills up fastest when you want to look at that like that. And we need to decide which new sweaters we truly keep us warm and which one we do not want to have in our wardrobe. Rare or orphan diseases pose a special challenge also to health technology assessment because they affect very few patients. And this means also that often the study samples are quite small, the evidence is quite uncertain, and the prices are often very high. Decision makers face here a clear tension. Ethically, we want to support people, or they want to support people with severe rare conditions, but most of these treatments do not meet the usual cost effectiveness thresholds. That means also that we maybe have to look at other measures and other methods to look at this not only from a cost effectiveness framework, maybe. Countries therefore also respond quite differently to these challenges. Some raise their thresholds, for example, because then they still can look with the traditional methods of cost effectiveness, but they will increase the threshold for these diseases, and others use maybe special funds and conditional reimbursement under other circumstances. But the central question always remains, how much are we as a society willing to pay to help a small number of patients, and what is actually also affordable? So while these medicines begin often as a niche of innovations, another study, which is presented here on the right side, find out that many of those later extend the market exclusivity of 10 years, actually going up to 22 years. And they are first starting as very small and niche products and get expanded to other disease areas and turn out to be very major cash cows for pharmaceutical industry. And the question is then if the high prices were justified in at the very beginning, and maybe also how we can deal with these kind of situations. Last but not least, I want to also highlight ATMPs, advanced therapeutic medicinal products. For example, gene and cell therapies. They are very exciting also to look at because they are one of the most complex innovations we face currently in health technology assessments. They are often given only once, so this is often a one-time therapy. Think about CAR T-cell therapy, but also other like Zolgensma or Livmelzi. Sometimes with a promise also to have a lifelong benefit. The upfront costs are very high, between 300,000 euros per patient, even going up to 2.5 million per patient. The benefit is that they have to be given once, and that then hopefully the effects also last a lifetime. But the challenge is that we rarely have enough data, long-term data, to know whether that benefit really lasts. And at the same time, the upfront costs are extremely high. So this is something we have to deal with now. We need to pay now, but the effects will materialize hopefully only in the future. And this combination of high price and very uncertain long-term effects make it very difficult for payers to judge the cost effectiveness. And countries in Europe, but also outside, are experimenting with many new solutions. For example, outcome-based payment agreements or installment methods and models. Some even call it a Netflix model of monthly payments, for example, or conditional reimbursement. and that really depends on real-world situations. This goes beyond the scope of this presentation, beyond what cost effectiveness in HTA is. So maybe something for a future seminar. I want to turn to the future of HTA also a little bit in a couple of slides. And looking ahead, health technology assessment will keep evolving for several important lines. And some of them come to mind. For example, the use of real-world evidence will grow because it's possible to link clinical registries and long-term follow-up data to see how treatments actually perform in real life. So we do not have to rely only on clinical trials and the data that is published. And second, equity considerations will become more prominent. Decision makers will look beyond efficiency and include also severity, unmet need, broader societal value, because not all of the value aspects are actually captured at the moment in economic evaluation, and hence also not directly in health technology assessment. And third development is the inclusion of environmental impact. I was today at a conference here in Rotterdam on the planetary health annual meeting. Here is also discussed how can we and should we assign not only costs per quality, but also costs per ton of CO2 avoided for new medicines. And should we or can we actually include those environmental impact considerations into economic evaluations and also into HTA? And still, even if this is something that is already going on, the EU joint HTA assessment in the form of the joint clinical assessments due to the EU HTA regulation, this is something that will really shake up and shape how we look at HTA. Clinical assessments will be done just once for all member states at the same time. And then also the economic aspects, they will remain at national level. So we really have to see how this plays out. And this is also something that ASCERTAIN is looking at. So throughout this talk, I have borrowed the image of the wardrobe to describe how health systems decide which treatments to keep and which new ones to add. And in many ways, ASCERTAIN is about helping countries organize that wardrobe together after the joint clinical assessment that is already been done at the European level for more transparently, more consistently, and with everyone on the table. In this project, my colleagues and I work with universities, payers, patients, industry partners from across Europe. And one part of ASCERTAIN is looking at pricing, how to set fair prices for innovative therapies that both improve access for patients, but still stimulate enough for entrepreneurs to invest and to perform R&D, research and development. Another aspect is developing open and dynamic cost effectiveness models because we do not want to keep this in a closed environment. We want to make it possible that these models can be used and reused and updated throughout the treatment life cycle, so also for future iterations and when new medicines come into the market. And a third work package is focusing on reimbursement models, looking and exploring how new therapies should enter the wardrobe and how to reassess them as new evidence is emerging. And finally, we are building a web-based ASCERTAIN platform, which we are currently doing. And essentially, this is an open digital wardrobe where all these different models, pricing, cost effectiveness, and reimbursement are coming together, where all these models and the data can be stored, they can be explored and shared with decision makers across Europe to also help this process. I have three key takeaway messages. First is cost effectiveness is ultimately about making choices. It's about deciding which treatments earn their place in the healthcare wardrobe and which ones do not. It is not about denying care. It's not about saying no. It is not about saving costs, but about using limited resources wisely to maximize health for all. Second, the decisions are not purely technical. They are shaped by values, fairness, severity, and what society considers a meaningful health gain. And third, the future of health technology assessment lies in openness, in open data, in open models, in open dialogue, things that we do within ASCERTAIN. And also by sharing our evidence and our reasoning, we can help every country in Europe, but also beyond, to make more transparent, consistent, but also more fair decisions about access to care and maybe also hopefully speed up access to care. So I have one exit ticket we can also use for the discussion. My question to you would be, do you feel more confident explaining cost effectiveness to others? Yes, not yet, or somewhat. I leave some references from my talk, and thank you very much for listening. I'm very much looking forward to the discussion.
Thank you very much, Frederick. Thank you for a very comprehensive take on HTA and cost effectiveness. And see, we have already questions coming through. First one is, are patients involved in cost effectiveness decisions? Do they get to say what they value most?
I would say so. It depends, of course, per country, and it's also between direct and indirect involvement. Um, when we do cost effectiveness analyses and the models and the calculations, and this really heavily depends on the project. I worked on projects where we closely worked with usually patient representatives and organizations that get feedback along the way for the model also and for the output that we calculate. But we are usually here. I work at the university, not making the final decisions. So we write reports, we do the analyses, and we share this with decision makers. I know that decision makers also involve patients, but I don't know at what level they would be able to say, even if something would be considered not cost effective, if they would be able to say, "No, we want it anyways," what the power of that would be, if this is answering the question.
Um, well, I think the person who asked the question, if you'd like to ask for more clarification, please do so in the chat. Meanwhile, we do have another question. Is patient quality of life an important factor in cost effectiveness analysis?
I would say it's one of the major factors in cost effectiveness analysis, because as I explained, cost effectiveness analysis is looking at costs and effects. And the main outcome in terms of effects will always, or mostly always be quality adjusted life years. There is, of course, some studies where quality adjusted life years are not possible to integrate because they cannot be measured. Think about, for example, patients on the intensive care, patients in coma. We cannot ask them for quality of life. What we will then do is often also ask their caretakers or even nurses or doctors what quality of life would be. Usually, this will be very, very low, of course. So we can integrate this also in these levels, but then with much more uncertainty. But they do find their way into cost effectiveness analysis always through the quality adjusted life year. And then what we do is we subtract the difference in costs. We divide this by the difference in effects, here QALYs, and this will give the incremental cost effectiveness ratio, which is then including quality of life in the outcome measure, and then based on this, decisions will be made. So yes, this is included.
But it doesn't mean that anyone is going and asking patients directly, what do you think that would be the most important aspects of quality of life that should be included?
So the most important aspects, we have different questionnaires that ask quality of life. They can be disease specific. They can also be a little bit more generic. Some questions that everybody can fill out all the time. This is, for example, of whether patients have pain, whether they can move, whether they have anxiety, so if they're anxious. Many different domains that we ask there. The challenge is always it needs to be comparable, because when we think of the wardrobe example, we want to make choices within cancer care, for example, but also we need to do them within the healthcare system because putting more into one shelf of the wardrobe means also we have to take it out from somewhere else. Otherwise, the shelves will burst. It needs to be comparable across diseases, and this is very much a challenge, of course, to find a questionnaire that is generic enough to make decisions across different disease areas, but is also specific enough to capture the specifics of certain diseases. So we look at this in many different ways. Some are better to be can be easier integrated into cost effectiveness analysis than others.
Thank you. There's a question about, is cost effectiveness used only for medicines, or are they used for in any other parts in healthcare, say in other products or services, for example?
Yeah, that's a very good question. I had the same question today, and the answer surprised someone in the audience because it's health technology assessment. So, in the health technology, it's often a blurry, maybe a blurry thing. So, it's not only medicines. Health technologies can be medical devices, for example, but can also be interventions. For example, think about when you go look in mental health, cognitive behavioral therapy, but can also be healthcare programs on a more broader scale. So health technology sounds very technological, and we often maybe I also in the beginning thought it's mostly about medical devices. Even it's about a technology, something technical, but it is medicines, therapies, yeah, can be anything related to health. The most important part is, of course, that we have a comparison, that we can compare one to another. And if we have nothing to compare, then this is the standard of care, maybe in medicine, it could be placebo or just the way we did it before, maybe without the health technology, without the health intervention. So this can be many, many different forms, the health technology.
Thank you. Um, this is a very interesting concept. So there's a question about if health authorities use social return on investment metrics.
Um, Health authorities, um, there, there is something but I don't personally do research on this. There is indeed different concepts of social return on investment, but I can not speak to this. I know that I know also who's doing the research here at the department on that. If you are interested, I think my email is on the last slide. Please send me an email. And I will bring you in contact with the person that is doing research on this. I personally do not, um, but yeah, this is done.
Thank you. Um, there's an interesting question about some of the costs can be linked to dosage and also length of treatment.
Mhm.
See if I understand correctly the question. It says, do you know of any trials comparing prescribed versus lower dosage and then reduced treatment periods to evaluate extra PFS per year of treatment? For example, in one country, you can have the protocol is to give a specific drug for 4 years, but there are diminishing return with each year of treatment. So perhaps it could save costs by giving the medicine only for 3 years.
Yeah. I think I know where this question is going, and this is indeed studied in different areas in different ways. I was involved in a study, for example, for first episode psychosis drugs, where you can think of maintaining for 1 year or maybe gradually decreasing the drug over time. This, of course, has implications on costs, but also has implications on side effects, potential side effects, while we, of course, want to maintain the same effectiveness. The same goes for cancer drugs also. There's different dosing regimens. Some of them can be even given at lower dosages, maybe at shorter intervals, maybe saving costs, maybe saving adverse events, and so on. And even the mode of administration is tested. Can some of the drugs be given subcutaneously, so basically in the skin instead of having an infusion? There are possibilities, they are evolving. Some of them can even be taken orally, so you can take a pill instead of an infusion or a needle. Um, the major problem with these assessments is often if they are not used for reimbursement purposes. So if this is not used or needed to reimburse a drug, then it is the question is, who wants to do or who is doing these studies. You first have to have an RCT, which is a very costly thing to do and thing to have. Pharmaceutical industry is using these studies to also get approval for marketing at the European Medicine Agency. So most of the clinical trials are sponsored by the pharmaceutical companies to get their drug on the market. And this is basically also what is used for cost effectiveness analysis as the evidence base. Um, there's, of course, possibilities also to run clinical trials for lower dosages, maybe compared to the standard dosage, but often they are not run by the pharmaceutical companies because the drug is already reimbursed and on the market. But hospitals, for example, or researchers, when they have the critical mass of also finding funding for that, they can do this, of course, and this has been done. And there are some studies out there. If you are interested, I don't have them on the tip of my tongue, but send me an email. I have one or two cost effectiveness analyses also done by colleagues here in the department that I can share with you if you are interested in this regard. But it's difficult to get the trials funded and also maybe to have the interest in doing and performing these studies.
Thank you. Just a quick explanation. You mentioned RCTs. If anyone is not really aware, would you like to explain just real quickly anything around, not just the acronym, but if there's any particular difference between using an RCT versus any other studies and any implications within the cost effectiveness analysis?
This is what I like about this topic always. You always, when you start discussing about HTA, economic evaluation, you always go deeper layers, and there's many different aspects that I cannot highlight in 45 minutes. But the very important point here is that we do clinical trials to test whether medicines, for example, are safe and effective to give to patients. And this is done in different clinical trial phases. First of all, there's testing in a laboratory, then there's clinical phase one testing, just about looking, are there side effects, is this safe to give? Then phase two testing with only a couple of patients to see how they react to it. And then we come to the gold standard, so to say, of comparison, which is a randomized clinical control trial, an RCT, also referred often to as phase three clinical trial, where the new medicine is given to a handful of patients compared to patients that did not receive the medicine. They are randomized because then we can assume that the only difference between the outcomes of these two patient groups is given the treatment or not. Because if we have enough sample size, we can assume that the rest of the characteristics, when randomized, are the same between the two patient groups. So the only thing that really changed between those is the medicine. And then we can say people actually live longer because of the medicine and not because of some other characteristics. And this is the gold standard for the evidence base that we would like to use. But we also see in recent years that medicines come to the market, and this is especially for ATMPs. Think about, for example, CAR T-cell therapy that have such promising effects also that it would be actually unethical to wait for a phase three clinical trial, because that would mean, in effect, that we would randomize people that need the medication into a group that actually receives a very promising treatment versus another group that does not receive the promising treatment. And because we only want the treatment to be different, we would give something like placebo. We would actually make it look like the other group would get the same treatment, because then only we can make sure that the difference is due to the treatment. And this is unethical in some regard, because if we already have clues that this is a very good medicine, then why should we do that? Why should we not give this to other patients as well? But this leaves us often also with a lot of uncertainty about whether the longer and the better outcomes are really due to the treatment. And this is something that we struggle with in economic evaluation, especially with these kinds of treatments. How do we incorporate this evidence base into our models, and how do we communicate this then to the decision maker? Because they want to also know in how certain are you about this result? How certain are you that this is cost effective or this is not cost effective?
Thank you. See that there's a question you talked about this, but perhaps for any of the participants who join a little bit later, maybe would be worth reminding a bit as well. Someone asked, does cost effectiveness calculation only include the product costs or also associated costs like hospitalization, supportive care, side effect management?
Yeah, that's a good question because it's often that we think when we have the drug cost, so the price that a pharma company wants to, for example, sell the drug. This is not the whole picture. We know, especially also coming again to ATMPs, CAR T cell therapy, for example, patients need to be prepared in order to receive the treatment. Patients also need more care after receiving the treatment. Maybe there are also side effects due to the treatment. Also, they all happen within the healthcare system. So if we give a new medicine, it's only fair also to look at those extra costs that are maybe if there are more side effects, there are more costs. So we want to include those as well. So we have these different layers. We look at health care costs, so everything that happens in the healthcare sector, which would be, for example, the medicine, buying it, but also giving it. There's a huge difference whether we can prescribe tablets that patients can take at home, or we have to give it as an infusion where patients need to come to the hospital, and maybe also everything in terms of side effects and administration. So there's a huge palette to consider. Also, patients staying in the hospitals maybe 2 days less or longer due to one medicine. This is included. And then when we also look at other sectors, not only the healthcare sector, we would also look to patient and family costs. For example, do patients need to travel more often to the hospital, maybe also for follow-up care, to a general practitioner? Do they have out-of-pocket expenses? Do they need someone that cares for them? So, yeah, taking care of the patients, this is also costs. And also, can they maybe return to work earlier than before? This is also included.
Thank you. For therapies such as CAR T, how are the benefits assessed compared to existing therapies? Do they need to compare them with other CAR Ts? Can they compare them with whatever standard of care is available in the country? Because you mentioned also in your presentation that these are long-term health outcomes which are different from, let's say, the more standard therapies. How are these outcomes considered when therapies such as other ATMPs are generally considered, and CAR Ts in particular?
So the big challenge about these therapies is often that we need to rely on the data that is already collected through the clinical trials, and often those that are done to also get market access decisions from, for example, the European Medicine Agency who would issue the centralized market access for these therapies throughout Europe. This is based on clinical trials. Coming back to this RCT phase 3 clinical trial, preferably, but for some of them, like for example, CAR T cell therapy, to a certain extent, this is not done in a phase 3 trial, but only phase 2. And the phase 2 trial does not have a comparator. So the problem is now the different countries in Europe, they structure their health system differently. So some standard of care that's available in Germany might not be, for example, available in Poland or in other countries. So even there, the standard of care very much differs between the different countries. And the problem is often that the data that is gathered in clinical trials, be it phase 2 or phase 3. And so any comparison can be then done or needs to be done with mathematical models, with also maybe patient matching. Clinical registries play a very big role, especially for those when we only have phase 2 clinical trial. So we need somehow of a comparison. We need to know how much better is CAR T cell therapy performing to a standard of care. And the standard of care or the comparator, this needs to be relevant for the country where this is assessed. And this is also why it's so difficult sometimes to even have a joint clinical assessment where we have all this data together. But then every country also has a very different landscape of maybe available comparators. So they need to make their own decisions. And this is, I think, also one of the choices that has been made. We can standardize, we can centralize many, many different things and many aspects, but they still need to be meaningful for the different countries. And this is something that needs to be done from a country perspective. So there will always be a layer of also looking at are the outcomes relevant for my country? Are the comparators relevant for my country? And often the problem is if the outcomes have not been collected, then it's very difficult to include them. Of course, assumptions are always possible, but we want some kind of clarity and certainty also. We cannot base everything on assumptions only.
That also explain why well, it would be, I suppose, extremely difficult to have an economic common assessment at this point, where we only have a clinical assessment of the HTA at the EU level, and then economic, the ethical, and all the other factors, they still remain very much at the country level then.
Exactly. And this is especially the challenge that we in Ascertain want to take on, because also there, it's not impossible. It is maybe we are far away from one common economic assessment, and I think nobody wants that as well. But what we can do is there are many, many different aspects in how we compare and how we model, how we calculate things, so to say, that can be streamlined and that can be made easier. And we are working with colleagues, for example, in Norway, looking at the same data set and coming to different conclusions. How can we solve this puzzle, basically? And many things are so different that you cannot standardize. But what we are interested is in the aspects that can be standardized and that can be made easier, so that only that we can focus more on the very different things between countries, and everything that is comparable we take into these models. And this is what we work for in Ascertain.
Thank you. You used often in your presentation the metaphor of the wardrobe to think of health budgets in each
Yeah.
country. There's a question on saying it seems that in many countries the wardrobe it's almost full, or it's getting like it's full. Would that drive prices down, or would might impact innovation as well, because the health budgets seems to be challenged?
Um, yes and no. I think the wardrobe is full in most countries already. You see this also. Most countries will yearly on a yearly basis increase also the contributions that people have to make through to health insurance. Also, often you will see this in every country if you at least read the newspaper, that healthcare is so expensive and that new medicines that come on the market are even this is basically buying a new sweater and not knowing where to put it into the wardrobe because it's already full, and we struggle taking something out. And at some point we need to take them out from the shelf of t-shirts to put the sweater in there because it's too full. And the problem at some point will be that we cannot buy new sweaters, and some countries actually cannot afford new therapies. This would also mean that they are not reimbursed, that they are not paid for. And then you can think, the pharmaceutical companies that do these research and development efforts, if the product that they are trying to sell is not bought, then the question is, should we invest in R&D more or to the same extent? So will that drive the prices down? Of course, there's some kind of competition. Um, I think at the moment, looking a little bit more on the global perspective, what will drive R&D is more geopolitical considerations. If you look, for example, at the United States, that say that they paid too much for medicines in the last decades and want to reduce the prices. I think this is a big problem for R&D. If these prices are reduced, there's much less for pharma, for example, to gain. That would mean that the prices need to either increase somewhere else or that research and development is just going down because the revenue is not there anymore. And then the question is, should pharmaceutical companies still invest in R&D if they cannot sell their products at a high price? So if a global player like the United States is who effectively also subsidized research and development for many other countries as well, is going that route. The question is, yeah, I think the answer is we wouldn't probably see a decrease in prices anytime soon, I think.
Thank you. Sort of connected to what you just mentioning right now. There is a question about why are prices negotiated with the pharma only? Why the public is not involved? If the public would involve, would this make negotiations fair or more fair?
Well, I think this is getting into political discussions, which I also like. But well, you know, you could argue depending on the country, of course, and on the healthcare system. Pharmaceutical company comes with a new medicine and it comes with a new price. So who's the payer? And often the payer, these are also government decisions saying, you know, what needs to be reimbursed in the basic benefit package. At least in the Netherlands, this is the case. So this is a political thing. Why would the political representatives not be society? So in somehow, I think they are involved. If you mean that maybe not the right people are involved, then the question is who should be involved? Who do you vote for these people, and where do you place them in place in these political systems to make these decisions? I think what we also should not forget is that one on the other side. Pension funds, for example, are also part of this global game, and they also invest in pharma quite considerably, and they get quite some return on investment as well. So this also somehow maybe benefits then society in another way that you know it's very difficult to assess, and also there for certainly it's not benefiting everybody, but this is a very complex system of who should you know benefit and who should make decisions. At the end, these decisions need to be made for the entire society, basically for everybody who pays. It's not only one specific patient group. It's not specific other people. It is basically the payers that need to decide what to pay for and also to find a relatively fair assessment of what to pay for. This is extremely difficult. And luckily, this is also outside of my reach somehow, of my, you know, my expertise also, because I'm more into this modeling and these calculations. But it is a very interesting thoughts and a very interesting discussion, which I don't have the answer to,
Mm.
and I think many people don't. Um, but maybe there's someone also in the audience that has. But the problem is, you know, how to change this in a meaningful, in a fair and a just way.
Um, we talked about how important are the economic evaluations. Why is it necessary for them to be done at the country level? Why? Because there are differences. But we do have a question of is it possible, or are there examples for countries to come together and do these cost effectiveness calculations together, or to follow what other countries have decided on this?
Yeah, there is something like, for example, Benelux AI, which is Belgium, Netherlands, Luxembourg, Austria, and Ireland also at some point joined this, where they say, okay, we can look at these efforts together, and we can make these economic models, we can make the calculations, and then everybody is just inserting their prices. basically something that we also want to do in Ascertain, having one core model that countries can use, and then they just need to change the prices. They just need to say, okay, no, we are not looking at this specific cost item. We are not looking at this. So to make it easier, and this has been done in the past and is still doing. And you can also think about other aspects like joint procurement, which means that countries join together to buy medicines, not as different countries, because also here you have, of course, on the one side, global acting pharma companies that have their main headquarters often in the United States, but they have also many other headquarters around Europe. But they do it on a global level, and they compete with the Netherlands separately, with Belgium separately, with other countries separately, and make their own um, um, you know um, um, negotiations. Why not join together and also be stronger in, for example, or Benelux AI or other countries join together and say, okay, we buy the medicine not as single countries, but um, as one conglomerate or something like that. But if you look at the political landscape, and then we move to politics and geopolitics again, um, it is already difficult for some countries to, to find ways to go forward within a country, let alone the European idea of growing together. I think one important major step is already towards joint clinical assessment, so that all the different European countries look at least at the evidence base together. And there's one European report. Um, and this happens now in 2025. It's just the first step. And I hope this will turn out well so that we can take on the other challenges as well in the future. But right now, I think we are moving forward, and I think we should not forget to look back and see from where we are coming. And yeah, the next steps in are on the horizon, but which directions to take to reach them, this is a different question.
Thank you. Have more questions, but I would like to come back to patients toward the end as well. So you mentioned that there is patient involvement in assessment, in decision making in some cases. Can you tell us a little bit more on how the patient's perspective are weighted?
Yeah, that's a difficult thing to ask, because how they are weighted would also imply that there's something like a methodological thing to include them, which in many countries and in many assessments there's not. If you look back at the or like if you remember back the different domains of health technology assessment, you had the top level of health technology assessment, which is really about the medicine, about the effectiveness, about the safety, and all these things. Then you go to the lower level, not the lower level, sorry, the lower part, which is not meant, the cost effectiveness side, for example. So the part that is done nationally. And we have the cost effectiveness, we have legal aspects, we have ethical aspects, and so on. There, often we have patient reports, for example, also patient organizations being involved and giving their opinion about also the economic studies that we have done, but also on the top level, patient-reported outcome measures, patient-reported experiences. They are also often and increasingly, luckily, included in clinical trials. So they find their way into different aspects and also at different levels. So somehow they are baked in to the clinical effectiveness, you could say. They're also baked in into economic evaluation, because they are taking it from the clinical side. They can also involve patients more clearly in the process. So we've worked on economic models where we um, always were in contact with the patient advocacy and with the patient groups about the models that we did, about the assumptions that we do, about effects, about costs, and so on. They are often very critical, and this is very good to have, because, yeah, we cannot oversee all the aspects all the time. So then these aspects are also influencing the way that we do the analyses. So they are also, it's difficult to say into how they are weighted, because they are often also a little bit more subtle than there actually are. But then there's also full reports from patient organizations. I know, at least in the Netherlands, if you want to do a clinical trial that is funded by public funding, ZonMW, for example, this will be sent to patient federations. They will also look at how the trial is set up. They will also look at if this is any meaningful for patients, if the outcomes are meaningful for patients. Because what we want to avoid, of course, at the end of the day, is also just doing clinical studies just for the sake of clinical studies if they do not help patients ultimately.
Um, at the end, once there is a decision on cost effectiveness, can that decision be appealed, for example, by a patient organization or any other group?
That's a very interesting thought and question. For the Netherlands, I can say that these very practically, we would do, for example, a cost effectiveness analysis. We would have a certain outcome. And let's say, for the sake of the argument, that the outcome is that a medicine is not cost effective. Then we would make this claim based on the analysis that medicine is not cost effective. This would go to the Dutch Healthcare Institute. They would write a report. They would write the report to the Minister of Health for these, who's then going into the negotiations about the price. They would then say it's not cost effective. We can actually not reimburse it. And often it is because the price is just too high. If you would decrease the price, you have this the incremental cost effectiveness ratio, the difference in costs divided by the difference in effects. Often, if you do something on the top part of this the formula, you decrease the costs for the new treatment, then the difference is not that high anymore. Then also the outcome is more favorable. So that means if you decrease the cost, then it's cost effective, we can reimburse it. The problem is often that these reimbursements, like these negotiations, are done in behind closed doors. So we can, of course, say if you get a 40% discount, then the medicine is cost effective. The question is, are these teams actually getting a 40% discount? There's some because they need to keep this also confidential. There's some research. I mean, they bring out the numbers for themselves and they say, well, in the last year, we on average reached a 20 to 30% discount for most of the medicines. Yeah, so but this is still behind closed doors. This is where the decisions are happening. I don't think there's a formal appeal, but yeah, this is a legal question. I don't know, or like more, I wouldn't know if there's a legal possibility of patient organizations to say that they want to appeal the decision. Probably there is, maybe there is somewhere, but it would be very difficult to, I think, substantiate the claim because you would have to maybe also have all the different evidence on costs and effects, which are maybe also difficult to get or yeah, but I wouldn't know if there's a clear possibility to appeal to these decisions.
Thank you. I think that you touched on the issue of transparency as well in your answer, because we had another question about where could the public find information about pricing and how pricing, what were the prices that were negotiated in each country, and that is maybe would be a good idea at some point, but it's unfortunately not possible at this point.
That's a question.
That's what I'm understanding also of what
Yes,
you
yes.
just
So
said,
we
because
we
these are
talk.
secret negotiations and then the outcomes are not really released to the public.
Yeah, so we talk in this case, we talk about list prices. So the prices
Hmm.
that is listed in a country.
Hmm.
It is very different for countries between countries how they manage these list prices. In the Netherlands, there is a website where you can look up the prices. This is medicijnkosten.nl. There you can look for your medicine and you would see what the list price is. In Germany, I think this is the Rote Liste, the red list, so to say. It's a big book,
Hmm.
actually. It used to
Hmm.
be a book, but it's online available where you can look up medicines and you can look up medicine prices. The downside is you have to prove, I think, that you are working as a healthcare professional. You have to prove this, and only then you get access to this database. And I think this even costs something to have access to the database. There's also other countries that more openly publish these prices, and others do not. The problem with these list prices is that we know that these are not the prices that are actually paid for, because the system is even more complex than just one party making a negotiation with, for example, the pharmaceutical industry. We know that negotiations are happening on many different levels. Hospitals, for example, can also negotiate prices again with the pharmaceutical company. You can imagine if you have a big university hospital, maybe in a region that has a lot of patients, they have a different negotiation power with the pharmaceutical industry, especially if there are different alternatives available. So negotiations happen at very, very different level, like many different levels, and also with different power asymmetry. So yeah, so the prices that are, even if we would know the list prices for all countries, which are difficult to retrieve, this would not tell us the true story.
Thank you, Frederick. I think we could talk about this subject probably for a lot more time. Unfortunately, I think we came to the end of today's webinar. I'd like to thank you very much for the time and all the knowledge that you've shared with us. I'd like to thank the participants and those who posted, had a lot of questions. If there's anyone that would have further questions, I would like to get in contact with you. Should either contact you directly or can contact us, and we can put them in direct contact with you.
I
Um,
shared my on the last slide. I think I shared my email address. Please feel free to send me an email for questions that you might have, or otherwise critique or anything else is welcome. Thank you very much for having me. It was a big pleasure talking to you, and also especially having this discussion with you in the audience.
Thank you so much. Thank you everyone again. Have a really wonderful evening. Bye
Thank
bye.
you. Goodbye.